Christina, coming back to you, I want you to concentrate now on the low-risk patient. They don't have any cardiovascular risk factors. They're not as aged as most of the panel members are today, over 60. They haven't had a thrombotic episode. They might be having microcirculatory symptoms, dizziness or fatigue or confusion, just trouble finding words, whatever it might be, migraine headaches, for example. Comment on the use of phlebotomy and low-dose aspirin in that group of patients. And does the patient have to have symptoms for you to initiate phlebotomy and aspirin therapy for that low-risk patient?
So for low-risk polycythemia vera patients, we approach all patients with low-dose aspirin, 81 milligrams or 100 milligrams daily, with concurrent phlebotomy, with that oh so important hematocrit role that Dr. Chameau had mentioned for that four-fold increase in thrombotic events or major or cardiovascular death. So, as a blanket recommendation, those that are diagnosed with low-risk PV, we approach those patients in that way. In regards to the symptoms, and so certainly there are a group of patients that will have significant associated microvascular symptoms. This kind of pathognomonic aquagenic pruritus, very symptomatic fatigue. In fact, this is the most commonly associated symptom, which was beautifully shown in the landmark study, that patients are afflicted with and can really affect their activities of daily living. And so I think in these patients that although we are definitely treating them and optimizing their hematocrit goal, decreasing their thrombotic risks with concurrent aspirin, we really need to be, again, assessing their symptom burden and addressing their symptom burden as an endpoint of care in combination with the hematologic parameters that we're really targeting. And so in regards to the microvascular symptoms, you can increase the dose of aspirin in some patients and have some modest benefit. There are some additive supportive care maneuvers that you certainly can entertain for the pruritus, and gabapentin has been used to some additional help. I'd be interested in some of the other panel's members in some of the other unique supportive care maneuvers that they're doing for symptom burden. But again, thinking about symptom burden as equally important as the hematologic profile and really letting that direct your therapy for your low-risk disease. And if it's not adequately controlled, then certainly thinking about second-line therapies.
Okay, and Christine, give them, our viewers a bit more understanding. How often are you monitoring a CBC or just a hematocrit in your patients with PV?
I think there's different phases. And so as you're initially meeting a patient, you're in more of this induction phase. You're really trying to be more aggressive, assess more aggressively, treat more aggressively with perhaps more frequent phlebotomies. And so in those patients, I'm seeing them every 2 to 4 weeks and making adjustments and recommendations for phlebotomy until we obtain really adequate control. Once they've attained really adequate both hematologic and symptomatic control, you can really start stretching out that monitoring frequency to every 2 to 3 months.